To the next speaker. Yeah, Dr. Neetu, she will be speaking on central serous retinochoroidopathy.
Yes. Good afternoon, everyone. I'll be starting with one of my case, and this was a 43-year-old male presented to me with the diminution of vision left eye, and the history of smoking and alcohol was present. On examination, the best corrected visual acuity in the right eye was 6.6 with N6, and the left eye it was 6.18 and N18. Anterior segment both eye was normal. This is the fundus photograph of the right eye. And this is a fundus photograph of the left eye, which is showing the oval elevation in the macular area. And this is the OCT of the same patient, the left eye, showing the macular edema. Subretinal fluid in the macular area. And as far as the treatment is concerned, as it was a first episode, being a self-limiting disease, the patient was advised lifestyle modification and observation. And after 2.5 months, the patient was followed up. The vision in the left eye improved to 6.6. This is the OCT of the same patient after the 2 months. It's resolved. And now coming to what is central serous chorioretinopathy, it's a sporadic disease of the outer blood retinal barrier characterized by detachment of the neurosensory retina at the macula with or without the focal epithelial detachment and alter RP, usually affecting the one eye. And it can be in two forms, acute or chronic. Acute generally resolves within the 4 months, and chronic, it is generally more than 4 to 6 months, and it has a widespread tract of RP atrophy. Coming to the pathogenesis, it could be idiopathic or the choroidal pathology related to the choroidal circulation. Various risk factors are there will be loss of autoregulation, which leads to hyperpermeability of the choroid vasculature, causing increase in the hydrostatic pressure, and following which barrier function is lost, causing neurosensory detachment. These are the various risk factors for the CSCR. There is type A personality, emotional stress, untreated hypertension, history of steroid use, GERD, Cushing's disease. The various symptoms and signs are, it could be acute central loss of the vision, metamorphopsia, micropsia, positive scotomas could be seen, and there could be loss of color saturation and contrast sensitivity, and improvement of the vision with the plus lenses. The fundus what we'll see is a round or oval elevation in the macular area. There could be yellowish subretinal deposits forming a spot pattern and the fluid between the RP in the neurosensory layer. It is commonly seen in the middle-aged man, 30 to 50 years, and the ratio is 6:1, and in patients older than 50 years, the ratio is 2:1. How do we classify? It's a typical and atypical. Atypical variant is a bullous variant, RP tear, and association with the other retinal disorders. Histologically, it can be classified into 3 types. Type 1 is detachment of the neurosensory, detachment of the sensory retina, with the type 2 is RP detachment. Type 3 is intermediate, which comprise both. And these are the fundus fluorescent angiography findings. The most common is the smokestack pattern, and the second one is the ink blot pattern. This is the OCT of the what we see in CSCR with the subretinal fluid with the focal PED. More recently, it shows increased choroidal thickness in some patients as compared to the normal eyes. Coming to the treatment, observation, lifestyle modification, which can lead to spontaneous resolution, medical treatment, oral antisteroid therapy or anxiolytics, and the lasers, PDT, low fluence PDT or micropulse yellow laser. So coming to the take-home message, detailed history is important, lifestyle modification is helpful, close follow-up is required. OCT is as a tool to follow up, and it's a chronic disease, and elderly patients to be approached differently. Thank you.
Thank you, Neetu, for that crisp presentation. But I have a doubt. A patient comes with CSR, what is your first line of treatment? Today he has come with a history of 1 week blurring of vision, ring scotoma kind of it.
1 week history. So complete and detailed history would be taken, and lifestyle modification would be advised.
Okay. see, because I want to tell so many people are there, CSR, don't take it simple because she has classified it in a different way. But now the evolving concept that is coming is the pachychoroid. That's why I stress
Okay.
the chorioretinopathy part of it.
Okay.
There is a CSR where the choroid is thin and normal. Probably there you, if you see a single leak which is extrafoveal, probably you go for laser. But the same patient, if there is a thickened choroid, this is a pachychoroid spectrum where there is a risk of neovascularization if you are going for a laser in these cases. So you should observe these and alert even if you commit for laser. Okay? And probably those cases may require injections in some cases. Okay? Thank you.